Post MI, acute papillary muscle rupture, you know, these are again rare things, you know, 0.01%. So you will hardly see acute papillary muscle rupture. I saw one case. This is the only case I operated papillary muscle rupture. So I'm presenting this case. He was a 60-year male patient. He was admitted with non-ST elevated myocardial infarction. He was stable. He was in the floor doing well. Yeah, he was kind of heart failure, but not too much. He was not on any oxygen. And he showed a moderate to severe MR, moderate LV dysfunction. LV ejection fraction was around 30%. But he was stable. So what happened? So next day, echo before rupture. This is before rupture, Howard. So you can see LV is dysfunction, RV is normal, LV is dilated, there is an LV dysfunction, and there is an MR, it is going into the pulmonary vein, it's a moderate to severe MR, and ejection fraction around 30%. So he was stable clinically. So next day, papillary muscle rupture happened. So his condition suddenly deteriorated, pulmonary edema, cardiogenic shock, was transferred from floor to CCU. He was intubated, inotropic vasopressor support, medical management, IVP and cath lab. He had a near arrest, you know, and a brief CPR. It wasn't complete, you know, severe bradycardia, few chest compressions, but he recovered. They gave a boluses of adrenaline, but he recovered. Then he was shifted back to the CCU, and then what we saw a papillary muscle rupture. You can see the papillary muscle is, and he had, and you know, now he had a torrential MR. MR was huge, severe MR, already had an LV dysfunction, posterior inferior. He also was finding there was an aneurysm in the posterior inferior aspect. So this is how it looks. So you see how the muscle is. It is the papillary muscle rupture. It is prolapsing into the LA, and it is a torrential MR now. And LV was already down. So we took him to the OR. So what we did, you know, we did a posterior medial papillary muscle rupture was complete. And then emergency MVR, we did a 29 tissue wallow through posterior transseptal approach. I usually do every case with superior transseptal approach. I don't go to the LA, and uneventful postoperative recovery. So you can see this intraoperative photograph where it was ruptured, and there was most of the mitral valve was prolapsing, and there was a torrential MR. So his follow-up more than 1 year now. He's doing fine. He's NVHA functional class 2. But unfortunately, he has a large aneurysm behind posterior inferior. I don't know what to do, but he's clinically fine. So it will be difficult to fix this pseudoaneurysm now. I have a plan, but let us see. But he's on follow-up so far. I think the same, you know, we presented this this article before. The incidence is very low, 0.01 to 0.05. And the papillary muscle, usually, you know, sometimes we see a single head. Sometimes we see two heads, but they are joined together. And sometimes we see multiple heads or two heads of the papillary muscle. So when there is a single head and whole, it is complete rupture. So most of the, you know, mitral valve most of the leaflets, they will prolapse. So it will have a torrential MR. So here usually we do a mitral valve replacement. Incomplete rupture or partial rupture, there are high chances of repairing these. So they are usually less symptomatic. You have a time to fix them if you wait, and you can repair them. But here usually the patients are sick, as in our case. So you have to do a mitral valve replacement.
Dr. Shabir?
Yes.
In exam, in oral exam, if any case like this come to me, I have to answer mitral valve replacement.
Yes. Yes.
Okay.
Yes. Yes.
But
yeah.
Okay, for experts, this is different story. But for us in the oral exam and graduation, I will not mention mitral valve repair, right?
I think so. If I'm an examiner, if you tell me I will do mitral valve replacement, then, you know, second comes, is there any chances of repair? When is the case, you know, there are chances of repair? You will say, particularly if there's a partial rupture or incomplete rupture, patient comes late, not in acute stage, is stable, taken, you know, after a couple of weeks into OR, because they are usually stable, because now the tissues are very, you know, good, and they can hold. But since I don't have much experience, these are very rare cases for me, I will go for the mitral valve replacement. Okay.
Okay, in repair, if it is partial, I have to reapproximate this papillary muscles.
Yes. So you have to, yeah. Suppose this, you can fix it with this head, right? Can you see?
Okay,
Yeah, you can
yes.
fix this head. That is enough. But be careful. It is a judgment call. Unless you have a mitral valve repair experience, I will suggest just go for the replacement.
Okay.
Yeah. As you said before, just replace it. So 2/3 of the patients have a partial or incomplete rupture. 1/3 have only complete rupture. Okay. So posterior medial papillary muscle rupture is 75% because of the single blood supply coming from the most of the time from the PDE. And anterolateral papillary muscle rupture is only 25%, usually because of the dual blood supply coming from the LAD or circumflex artery. The MI may be large or small. If just papillary muscle does not need, you should have a huge MI. Infarction may be subendocardial even, or transmural, and it is may be associated with VSR, or it may be pre-valve rupture, or there may be combination of these mechanical complications. Diagnosed, if it is a torrential, as we see in an acute complete rupture within few hours, 14 days after acute MI, even later. So sometimes, if the partial or incomplete, they may just present with MR and they may be just heart failure. They may not be diagnosed in time and they may come late. But in our case, the patient had a torrential acute complete rupture, they just collapse. So they can have pulmonary edema, hypotension, cardiogenic shock, heart failure, particularly in partial rupture. They have less MR, so they are, they can be taken urgently or electively. Apical systolic murmur and apical third heart sound. Usually they are, murmur, or then apical third heart sound can be seen, MR murmur. This MR murmur is usually seen in the incomplete. Incomplete, you don't see the MR, you don't see the murmur. You know why?
Because
Again,
it's
Shabir.
complete.
In complete rupture, you don't see the murmur, but in partial, you heard the murmur. You hear usually the murmur.
Because no gradient.
Because equalization of pressures, because as in our case scenario, there is a torrential MR, the LA pressure goes high, and there is hardly any, so the equalization of pressures, you hardly see a murmur in case of the complete. But in case of partial, there is not that much, there is a pressure gradient, so you may hear the murmur, particularly in the partial one. And it is not common, it's just seen in the 50% of the cases. Not in the VSR. VSR have a harsh murmur and it is widespread, and most of the time you can see even you can hear it. But mitral, in case of this one, acute MR due to partial rupture, you may not hear the murmur, maybe in 50% of the patients. So chest radiography, as we see, pulmonary edema, there will be congestion, and heart may be slightly enlarged depending on the setting, and left atrium is usually small because this is an acute setting. As you said, pulmonary Swan-Ganz catheter, it may exclude the presence of left to right shunt. It may help in differentiating VSR from the MVR, and the prominent V wave may be, as we see in the MR patients. Echocardiography is main diagnostic tool. Mitral valve leaflet becomes pale, it collapses. A rupture portion of the muscle may be directly visualized as a mass attached to the cardi. Differentiate between papillary muscle rupture and LV dysfunction. So I think echocardiography is the main. Sometimes, there may be not be rupture, there may be just a severe LV dysfunction, and and there may not be prolapse. I think this is same our case, as we saw the prolapsing the papillary muscle, torrential MR. If you have a total rupture, 25% of the patients treated non-surgically surviving more than 24 hours. So if the partial, they have a very good prognosis. More than 70% of patients survive first 24 hours, and 50% survive more than 1 month. So partial, they can be stable patients. So what is your confirmed, you have confirmed papillary muscle rupture, surgeon is notified, left heart cath is performed. If yes, transfer to OR for mitral valve surgery, patient unstable, IABP, put an IABP before transferring to the OR. If there is no left heart cath, you can do an angio and put an IABP in the cath lab and then go to the OR. This is just an outline. It is not like every patient should go follow this protocol, but this is a general guidelines how you should approach them. Technique of operation, general operation, distal anastomosis of the bicuspid grafts are performed before you touch the mitral valve, repair or replacement. This approach, the approach can be through the left atrium, but or superior transseptal approach. I do almost all cases through the superior transseptal approach. I do not open the left atrium. In total papillary muscle rupture, it is better to go for a straight way to the mitral valve replacement. But partial, if there is a partial rupture, and the caudal mechanism is intact, as we see in the anatomy, then experts can try mitral valve repair is feasible in such cases. So because of the rarity of this condition, only few surgical series have been reported. Mortality ranges from 18 to 20 or 22 or even higher has been some case reports depending on the patient profile. This is one of the study. It was in 2008. They did a 54 patients, and it was post AMI-Papillary muscle rupture from 18 to 2020, 2 decades. Coronary bypass was associated with lower operative mortality, so it is better to do a cabbage with them. Operative mortality overall was 18%. It was 67% in the first decade, and the second decade it was just 8.7% in them. And 5-year survival is good, 67%. There another one post MVR repair, post mitral valve repair, post myocardial infarction, papillary muscle rupture. I think it was a partial rupture. It was over like 2 decades, 9 consecutive patients. They did a repair. So intraoperative in hospital mortality was 0%. So none of the 9 patients died. Intraoperative repair failure, only 1 happened. Freedom from grade 3 or grade 4 mitral regurgitation was excellent. And 15-year survival was, their survival was just like a normal patients. So mitral valve repair for partial or incomplete is reliable and provides a good short and long term. So when you have a partial or caudal prolapse is not there great, you can just do a repair as well. So it is feasible. This is a systemic review of literature, mitral valve repair and post-MI, post-MI papillary muscle rupture, number of repairs, but this is very 6 cases, 3, 2, 4. But what I mean to say, there is a feasibility of doing a repair, particularly in case of the partial or incomplete ruptures. This is a recent study in 2018, and this is over a period of around 16 years. And they did 24 cases were there, and of papillary muscle rupture. Overall mortality was 12.5%, and the mortality was 12.5%. Thank you. I think we completed now our pre-var rupture and acute pre-var ruptures. Chronic pre-var rupture is a pseudoaneurysm, then is a papillary muscle rupture, and then the most common, and which is most of the literature about the ventricular septal rupture. I think this summarizes all of it. And I think if you have any questions, you can go ahead.
Thank you very much, Dr. Shabir. Hussein, Uthman, Faisal, Bayan, if you have any question for Dr. Shabir for the 3 topics, kindly you can ask.
Thank you, Dr. Shabir. It was very clear. Thank you.
Anybody has any questions? Okay, let us make a case scenario. You have a patient, 80 years old. I don't know, any one of you can take it case, and she is in CCU. You are a stop on call from surgical side. You got a call. We have a patient who has an post-MI VSR. Please come and assess and take him for surgery. So how you will approach him? 80 years female.
You will take short brief history, and yes, you assess the hemodynamic stability. You will see you will see the echo.
Yes.
And cath if it's done.
Okay. Now patient is relatively, hypotension, and you reach it there, and the cardiologist was putting in IABP. He put an IABP, and bedside echo showed a large anterior VSR, and creatinine is like 210. She is oliguric. Liver is a little bit higher sided. INR is 1.9, and uh, this is the present. This is the situation at the bedside.
So this patient clinically unstable, but the real question, she can tolerate the surgery or not? She is 80 years old, right?
Yes, so background of the patient now is like, the family says she was not much mobile. She goes to washroom and she does her hardly her activity, but the minimal she needs, she takes some stick to help her and goes to the washroom, and this is her activity. She had previously had a stroke and she recovered. There is no residual weakness, but overall, yeah, she is not that great.
If we can stabilize her before take her to the surgery, that will be best, because the and this time she will be very high risk, and I prefer to take her in her best situation. But if we cannot stabilize her, we have to take her with very high risk consent for morbidity and mortality.
Okay, now you talk to the you said this discuss it with the family, as you said, and the family said, let us observe her, let her get better. We will decide tomorrow. Cardiologist, you had a meeting, counseling with the family and cardiologist. Now you continue on IABP and some support measures. And next day, overnight, you come the morning. Now the patient is lactate is going high. Now it is 7, and she urine didn't improve. She makes 10 ml per hour, and INR is 2.5, and she need a high ventilatory support now, and yeah, she deteriorated overnight, and they called you again and they come and assess this patient about a possible surgery. So what you will do?
Yeah, now she become worse, and she developed multiple organ failure. I think I will not take her for surgery now. Let her stabilize, because with multiple organ failure, I don't know if she will recover after fixing the heart or not. If
Oh,
she is younger and less comorbidity, but I will take her.
okay. I will do the same. I will not take her to the OR. Because elderly patients who have limited frailty and have now advanced a shock state, I think it is unlikely they will recover. Similarly, if you have 40 years young man, and he came and he was on IABP, referred from other hospital, and his labs were enzymes were very high. His INR was 2.7, liver enzyme was high, creatinine was like 270, and he was not intubated. He was on 2-liter oxygen and was stable, and his LV function was around 40%, and RV was moderately dilated, and it is now like 4 days old MI, and they called you to the CCU for surgical opinion. How will proceed?
This patient hemodynamically stable, but increased parameter of other organs, most likely due to hypoperfusion state. If I can wait after till we complete 7 days, that will reflect better surgical outcome. So only 3 days remaining. I can push the surgery for 2 days, let them stabilize more, then I will take him for surgery.
Okay, you went on the bedside, patient was relatively stable. He was talking to you, he was saturating well, but he came with the high liver enzymes, INR was 2.5. So you suggested, what I will do, I put an IABP. I think he was already on IABP, and you put a plan, wait for this patient. And next 2 days, he was relatively stable. Liver was getting better. Kidney was getting better. The cardiologist, it was weekend now, Friday, and Saturday, Friday evening they came and they removed the IABP. And Friday daytime they removed the IAPP. Saturday now came morning and they called you and we removed the IAPP. Now the patient was he started deteriorating again. So now the creatinine was getting better initially for 2 days and now deteriorated after IABP removal. He was still he became tachypneic and liver sorry, his lungs become congested now and there is again a rise of the liver, not that much, but he start deteriorating after removal. Next day Saturday, it's a weekend, they call you, what you will do?
I will, if he start to deteriorate and become hemodynamically unstable, and already 7 days, that's mean less mortality if we compare to first or second day, and he's young with low comorbidity, I will take this patient to ER in emergency situation.
Yes, excellent. So it is the same scenario happened with me. The patient came in a bad shape. He became stable. I waited over a weekend. He deteriorated. Unfortunately, the cardiologist removed the IABP. I have to take him over a weekend I think in the evening time. I took him to OR. Alhamdulillah, he made a good recovery. So I think these patients, it is an individual judgment. It is difficult to, put a plan exactly. You have to see a case scenarios and case by case, case basis. Yes.
There is a rule of ECMO in patient with VSR.
Yes. Yes.
So for the patient in the first scenario, or the elderly patient, there is some people who does not want to put ECMO on elderly, but if it is feasible, and we put an ECMO and she improved, we will take her to surgery, right?
I think so. I think so because now this patient, 80 years, first of all, you may be hesitant to putting an ECMO. Now if you discuss with the family, it is very important to take a family into consideration. If the family says no, try your best, and you talked about ECMO to them is a possibility. The patient, the family is pushing and so no, try your best. Some people are there and you discuss with your hospital like a cardiologist and an ECMO team. There is always some protocols in the ECMO team. So you call an ECMO team who is responsible, they check your protocol. You should have a meeting with them. It is not the right way you put an ECMO. It should be, ECMO team is different. In our hospital, we need to discuss with them. So sometimes they're hesitant. They say, no, we don't have any good outcome. But if you can convince them as a cardiac surgeon, look guys, if you put an ECMO, she recovers, she starts, I will take her to OR. So you have a definite plan. So if you have a definite plan, then I will go with an ECMO and eventually I may fix it, yes. But all patients, if you'll say the ECMO and ECMO team discusses with the family and the outcome is very poor, and then may not, just stop here and just give a supportive care, just an IAVP, and if he recovers, yes. If not, and that is it. But definitely ECMO should be always a backup plan if you are planning to repair. You cannot put an ECMO when there is no definite plan. So yeah, if you have an ECMO, patient recovers, yes.
Thank you very much.